Good morning. Welcome to part 2 of this. I'm going to be, no, don't worry, there wasn't anything earlier. I'm talking about yesterday. We're going to start, and today what we're going to do, what we didn't talk about yesterday, which I sort of alluded to, various parts of the face that I injected and how did I inject it, what are the techniques I used. So this is going to be a step-by-step approach. Half of the discussion is going to be video. I think there's just no way better to show this than actually showing a video. As you remember, just with this first photograph, the changes that I think a large component of aging is really volume loss. And if you really look carefully at your patients and look at their old photographs, you'll start to see those changes are principally volume in nature and very little in gravity, at least according to my world paradigm. Remember that I like to try to make sure that we communicate this well to a patient, because sometimes the language we use is important so that they understand what we're trying to deliver. So what I like to say is that when we're youthful, we're grape. As we get older, we become a raisin. But if we take that raisin and we cut, pull, stretch it, we make it into a pea. And a pea does not look like a grape. It looks like a different thing. So we need to make them into grapes. In other words, return them back to their natural youth. But do we want to put a lot of fat in? No. As you know, this is about artistry and restraint. Just to remember again about this is baby fat is not what most women want. And if you start by telling them, look, we're not trying to make you look 18 or 20, and we're not trying to put a ton of fat in your face, they'll go, I think he gets it. I think the number one fear I have in my patients is being overfilled now. You see this in all the celebrities. And I think if you just put that out there before they even ask the question, they'll feel much more comfortable with you than if you wait for them to say, are you going to make me look like this? That's going to be too late. So say it before they even express that concern. Remember the shape changes, and remember that at 30, that oval shape that we talked about is that transitional period that I think is the most elegant. Does it mean they're going to look 30? No. Does it mean that they even want to look 30? Maybe, maybe not. But the ultimate goal is to understand beauty, and beauty in women is about this transitional phase of youth. Let's break it down now. So we're going to sort of break down the areas, because the cheek is not the cheek is not the cheek. It's a lot of small areas. So the cheek, to me, is divided into 2 areas. We'll go into this more in detail. It's the anterior cheek. So if you think about sort of the bony prominence right here, it's the anterior depression that occurs. That's the anterior cheek. The outer cheek is going to reside over the malar bone. So that is the lateral cheek. This is just ways for you to start to accentuate your learning, is to divide into small components. And then the buccal area, which we will further divide in a moment, is going to be the area obviously below that. And then the chin is going to be something that we may not think about, because oftentimes when we think about the chin, we think about the jowl, or we think about the mentum, the area where we would augment with a chin implant. But it actually, I call it the upside down U, which is the depression across the front. And it's not the mental sulcus. It's not, okay, we got to obliterate that line. It's the volume loss across the front chin and volume loss across the pre-jowl in a harmonious arc. And when you fill that area, even though the mental sulcus is still present, the shape is very, very elegant. So what is the objective? It's to create this oval. And you're going to try to help bring that into harmony. Okay, buccal. We talked about subdividing it. The central buccal is clearly just where there's a depression here, right in the center portion. And that's probably the most obvious area that we're going to talk about with buccal filling. But remember, when you see that scalloping laterally, when you're looking at a frontal view, and I encourage you again, focus on a frontal view for a patient, because that's the area, that is what's the most important. So whenever I sculpt, even if I'm using fillers, if I'm on the side sculpting like this, I'm always coming back and looking at the front. Am I over-exaggerating the flare? Because it may look great as you inject this way, but it looks terrible from a frontal view. Then you don't get a good result. And that's going to be the area below the arch, across here, even laterally in the subzygomatic region. So I call it a backfill or subzygomatic region. The area in the front, I don't often fill. You probably saw in all those ones I showed you, maybe 1 or 2 times a year I fill a little bit more medially. This is the medial buccal hollow. It's someone more advanced in age. They start having depression across here due to dental loss. But with good dentition, I don't think you get a lot of medial hollow unless there's a very, very great degree of hollow. The area you got to be careful when you fill this is because you can exaggerate sometimes the puppet line or the marionette line or the labial mandibular fold. So this is just showing you, this is a lady with all 3 areas needing to be filled. This is an area that just needed a drop in the buccal area because she's already wide, and I really pushed her front cheek and pushed her chin forward. This is a combination with blepharoplasty, upper and lower, as well as some resurfacing of the lower eyelid and some Botox. But the key point of this is not the ancillary techniques that I used, but the fact that she's wider, and you want to be really careful. Just because she's got a buccal hollow, you don't want to be aggressively filling it. It's an artistic element, and that's what I'm trying to encourage you to see, is that component. This lady here, if you look at her, she's wide, so I filled more central face to help bring out, de-accentuate the outer portion of the face. So that's, again, the concept of balance. So framing the eye is perhaps the most important thing we deliver, because remember, most women actually come to you focused around their mouth. But if you focus around the tiny little things that they see close up, you're not going to make them look better. Almost never do I get up this close to a face and go, oh yeah, that's what I need to fix. We're talking about a social distance, and you want to make that impact that's powerful. So bring their attention back to the eyes, because that's when I speak with you and you speak with me, you're concentrated on my eyes. I don't want you to be concentrated down here, because you're not. The only time you'll look at my mouth is if you're fixated on your own. But I want to make a more powerful social professional impact, and the eye is everything. So let's really mechanically break down the eye. Okay, sorry, let me go back one. Where am I? Okay, so this is an upper blepharoplasty combination with resurfacing, I did a plasma skin resurfacing and fat transfer. And I think in this case, when you see some crepiness along the edge, when it actually the skin hangs over the ciliary margin, a little bit of a very conservative, we're talking about just a few millimeters of skin removal only, is a good adjunctive procedure. This case where she has a sort of bug-eyed look, where it looks opened, doesn't need any kind of removal, doesn't need a blepharectomy, if you will, needs to have volume restored. And that's just a fat graft. This is the combination I mentioned earlier. This is a transconjunctival blepharoplasty, a conservative upper lid blepharoplasty in combination with resurfacing, Botox, and a fat transfer. This is a lady that's had, in my opinion, over-skeletonization of the eye. This is fat grafting forcefully placed in that transition of the bone going over the rim, so I can actually lower back that brow, or when I mean brow, I mean the soft tissue complex, not the hairy eyebrow. So let's break down the eye frame a little bit more in detail. So when we start with the medial component, and again, the video is going to be much more expository than what I can do just with words, but I sort of think about the middle area. So I'm going to go through both in more photographic sequencing as well as video, but I just want to sort of highlight the points that I fill. It's going to be the medial area, and then why do I divide medial from lateral? There's nothing different. It's just mechanically keep my numbers, how much volume I'm putting in more easily in record. Laterally, the nasolaryngral groove, the lateral canthus, and you really should focus on lateral canthus through a separate entrance. When I was first doing fat and I wasn't targeting the lateral canthus, I would see a lateral dip. You really have to hit that as a separate area. The lateral brow, this beautiful light reflex, and if you don't understand what beauty is in the lateral brow, go look at some scientific textbooks. They're known as Glamour, Allure, and Vogue, because they are what is natural. They're not, maybe retouched photographically, but they're not operated on. A lot of times we're so focused on looking at brow lifts and going, well, those are nice brow lifts, but is that really what's youthful? And I would argue in many cases not. And then that A-frame deformity, either due to previous upper aggressive blepharoplasty or due to just advanced aging, you get that notched appearance here. So look for that. And then just overall, a blending in that area. And sometimes I come back and add a little bit more where the transitional phase is. I just see this little dip laterally. I may come in from a lateral point and just nudge it until I see that area blending. So it's all about softening transitions around the eyes. Needle. This is just showing you after I've harvested with a few cc's negative pressure, the fat. I put a cap on one end, and then I pull off the back end of this, and then I cap it. Then sterilely I place it into the centrifuge. You don't need to. That's the other thing that's so important, is that people usually after this talk come up to me and go, how long did you do it? There's this rain dance voodoo with processing fat. I've worked with surgeons that have done it with washing. They've shown me beautiful long-term results. I've learned from my mentor, Mark Glassgold, about this, and he taught me how to just centrifuge it. I don't even know if he centrifuges anymore. I don't think it really matters. Just find someone that's done it for years, has shown longevity, and then copy that technique, because there's many ways to skin a cat, and this is just one of them. After you centrifuge for 3,000 RPM for 3 minutes is what I do. You get this super and infranatant. You want to pour off the supernatant first. You never do the infranatant, otherwise you won't get the top out. And then you let the infranatant drip out. And then you can knock out the oil. Just, you don't need to. I like to wick it for a couple minutes. The key thing is definitely don't cut the cotton fibers if you tuck it in there, because otherwise you're going to have foreign bodies. So definitely just stick it in there. And then you want to transfer over all these 10 cc's into a 25 cc syringe. One thing is important is look at your harvest as you're harvesting. I typically get about 50%. In other words, if I'm going to pull a 10 cc syringe out, I'll get 5 cc's usable fat. But clearly, if it's a bloody harvest and you're having a hard time, you're going to have to plan that you're going to only get 2 cc's out of that 10 cc's. You're going to have to harvest more to get what you want. Spin the first couple syringes, see if you're getting the yields. If you're not, you'll need more. And then the key with this, obviously, is you're putting the 25, you shake it down, let the air come out, and then push it back up so that you don't have fat spraying across the wall. And then you take out the air in there, and then you just transfer into these 1 cc syringes. Make sure there's going to be an air bubble at the end. You want to push the column all the way out and then back in. I'll be showing the videos of how to even do all this in detail. This is a video that I shot that I'll be doing in Las Vegas. I just don't have the time to show you how to harvest and process, but I'll have that in Las Vegas at Dr. Waldman's meeting. And then I always have a photograph of the patient in the room so that I can take a look at what's going on and referencing how much volume I need. These are the cannulas. The 1.2 millimeters are at the bottom, and then the 0.9. You can see how flimsy this is. I don't use a lot of 0.9 because it bends too easily, in my opinion. And then the conceptual thing from the textbook is just when people ask me what plane you're in, it's a feeling plane, and I'm going to walk you through verbally with photographic sequences what plane, and then I'm going to video show you so that you have a double reinforcement. But essentially what I'm doing is that most times it's just sort of a plane of least resistance, okay? I'm sorry, which is just in here, and then there's a deep plane. If you think of it that way, it's much easier. And when do I do what? Let me show you.